Craig Lammert. I'm a hepatologist at Indiana University. I'm also the executive director for the Autoimmune Hepatitis Association. I'm really pleased to join you today alongside Kezar Life Sciences, who are sponsoring this talk today, but also Dr. Ethan Weinberg with a talk titled The Truth About Clinical Trials, Debunking 4 Common Myths. So thanks for joining us, Dr. Weinberg. I appreciate it. Just a little bit about him. He's an assistant professor of clinical medicine at the University of Pennsylvania. He actually graduated from the University of Maryland Medical School back in 2009, and he finished his internal medicine residency and gastroenterology fellowship at Weill Cornell, and he did a postdoctoral fellowship at Rockefeller University in New York as well. So he's obviously very well traveled. He's been at Penn now for a number of years, and he leads the clinical trial piece for them. He's been an excellent collaborator within the realm of autoimmune liver disease, specifically autoimmune hepatitis. And just knowing him personally, there's no better clinical advocate for patients. So we're really honored to have him. Dr. Weinberg, thank you so much for joining us.
Thanks, Craig. I'm honored to speak to you this afternoon. I'm at University of Pennsylvania, and I have an interest in clinical trials and clinical trials for autoimmune hepatitis. I really want to be able to offer more therapies to my patients with liver disease, no matter what the liver disease is. So the title of my talk today is The Truth About Clinical Trials, Debunking 4 Common Myths of Clinical Trials. So in this webinar, I have a few different aims. I want to shed light on 4 common myths about clinical trials. I'm going to highlight some of the facts about clinical trial participation. And then I'm going to explain how Kezar's investigational drug, zetomipzomib, I'll be referring to it as Zeto, has the potential to treat adults living with autoimmune hepatitis in the Portola clinical trial. So what is a clinical trial? So clinical trials are research studies that are carefully designed to determine if an investigational drug is safe and effective. And they're at the heart of all medical advances and look at new ways to prevent, detect, or treat disease. And there are several phases of clinical trials, and we'll get into those a few slides later. But these phases take steps to assess an investigational drug's safety and effectiveness. And the goal of a clinical trial is to make a new, safe, and effective treatment available to the general public. So a few common myths about clinical trials. So a myth, what is a myth? It's a widely held but false belief or idea. And what I want to do is try to debunk these myths. And that means to expose the falseness of the idea. And so 4 common myths, and I'll go over those one by one and then in detail on the upcoming slides. So myth number 1, clinical trials are only used when all other options are exhausted. Myth number 2, I will only get a placebo if I do a clinical trial. Myth number 3, clinical trials are dangerous because they use experimental drugs. Myth number 4, and once I'm enrolled in a clinical trial, I'm not able to change my mind. So tackle these one at a time. Clinical trials are only used when all other options are exhausted. Myth number 1. So this is false. It's a myth, so it's false. And here's why. Clinical trials, they're looking for new ways to prevent, detect, or treat a disease. And the goal is to determine if a new drug is safe and to test that it is safe. And if it's effective, it can be used to improve the quality of life for people with a variety of illnesses. And they can offer an alternative for people who have exhausted for other treatments, but that's not the only thing that clinical trials are used for. Some trials are looking for people at various stages of their disease. So it could be the first-line treatment. It doesn't have to be something that is a last-line treatment. While other studies will look for people who have difficult-to-treat diseases like refractory autoimmune hepatitis. And participants with illnesses or diseases may participate and receive the experimental treatment, but will also receive supportive care and supervision. Myth number 2. The clinical trial will only give me placebo. This is also false. Here's why. So a clinical trial will never give you only placebo. Sometimes people refer to placebos as sugar pills without telling you about the possibility first. And this information is disclosed in the ICF, as we call it, the informed consent form. So yes, the word form and form is in there twice, informed consent form. Most clinical trials give placebo to some participants to compare the investigational drug being studied to understand how safe and effective the new treatment is for a specific disease. However, increasingly trials offer a later option for all participants to receive the experimental drug. This is often sort of an open label extension. Some trials are only have an open label and everyone gets the drug. And so it's important that when you're talking to a provider about a clinical trial, you understand what the design is. So many clinical trials, actually all clinical trials, will use some sort of standard of care as the background treatment for an investigational drug. And sometimes a placebo is used in that standard of care, and sometimes it's not. And placebos by themselves are used infrequently. Myth number 3. Clinical trials are dangerous because they use experimental drugs. So this is also false. And the safety of clinical trial participants is always the top priority. In order for a drug to be approved, it has to be shown to be, in general, the benefits need to outweigh the risks. And safety, and if a drug is considered unsafe, then that will be, the risk is often too high for the benefit. So the safety of clinical trials participants is always the top priority. We want to make sure that anyone in a clinical trial is safe. And clinical trial participants only receive the investigational drug after the drug has undergone extensive testing. So what does this testing mean? So new drugs are tested in people, but before that, they undergo rigorous preclinical and animal study testing, which are then reviewed by the FDA to determine whether it's safe to be given to people. So these will be done in various animals, and they're also done often in cells in the lab to see how they work. And tested at various levels. But even when the clinical trial is ongoing, the clinical trial team is frequently and extensively assessing the investigational drug to make sure it's safe for participants to continue in the study. That's why in most clinical trials, the visits that patients will have with their providers are much more frequent because we care about the safety of a patient when they're in we care about the safety of patients all the time, but in a clinical trial in particular, we want to make sure that there aren't any reactions or anything that we would, or side effects that we might see, we might be able to pick up on labs before we'd see symptoms of them. So how do researchers determine when to test investigational drugs in clinical trials? So this is where I alluded to earlier. There's different phases of clinical trials, and each phase has a purpose that helps researchers answer different questions. And volunteers are sought to participate. The exact number of volunteers depends on the disease being studied. And clinical trials that focus on rare diseases tend to have fewer participants in each phase because the disease affects fewer people. So it's the timeline to go from drug discovery to an approved drug is often many years, not always, but often. Usually there's laboratory studies. The sort of guidance here we have is about 3 to 6 years. And what we're looking for in these laboratory studies is sort of dosing and toxicity. And we look at this in preclinical and animal studies. And we'll also look at in cells in the lab before moving into humans. And the next thing we do is a phase 1 study. This says up to 100 people. It can be, they're often much smaller than 100 people, but it can be 100 people depending on the target audience. And we're looking at here, is it safe and what dose should we use? So phase 1, they're often divided up into sort of 2 phases. Sometimes it'll be a single dose, and that dose will go up and up and up in different people. And then they'll do multiple doses. And the phase 1 population can vary depending on who the target treatment is. Phase 2, this is where we see, does it hit the target is one of the, does it work? Does it effectively, or is there a sign that it will treat the disease in question? And this is where there's usually still some honing of the doses and the scheduling. Phase 2 can often be divided into 2A and 2B, and 2A tends to be smaller for shorter duration, and 2B tends to be larger, slightly longer duration. And then we get to the phase 3 study. This says up to 3,000 people. In liver disease studies, it's not usually that high. In cardiovascular disease studies, maybe we'll hit 3,000. In rare diseases, autoimmune liver diseases, a phase 3 study is not going to have 3,000 people. In the phase 3, and this is what's usually used to move forward with the FDA, what we want to do is get the final doses, final scheduling, make sure it works, it's better than what's already available, and make sure that it's safe and that the benefits of the medication outweigh the risks. After the phase 3 is done, then we move towards FDA approval. Companies are often meeting with the FDA in between or around each of these phases to make sure that they're all in alignment. The FDA provides guidance on what would be considered a successful trial, what would be considered not a successful trial. Even after the phase 3 is done, it takes some time to be able to review all of the information that occurred in that trial, and for the FDA to look over the study documents and provide their judgment as well. After FDA approval, we have post-marketing. Now we actually have things, we refer to it as post-marketing studies or phase 4 studies. And even if a drug is approved, there's still more information that we can gain to make sure that sort of the safety and benefits in the general population. And so there's still often studies, some of them are voluntary. They're not usually as time consuming for patients, but we want to be able to track what the effects of and how patients did that were on these medications in the few years, particularly after FDA approval. There are sometimes we find that they're safer. Sometimes we find that there are rare events that pop up that we need to be aware of that we weren't able to find out until it had been given into a wider number of patients. So myth 4, once I'm enrolled, I won't be able to change my mind. And this is untrue. This is false. As a participant in a clinical trial, you are always in full control of your treatment plan. And if you decide that you don't want to participate, you can withdraw at any time. When I am consenting patients for any study, I emphasize this again and again and again, because a clinical trial is always voluntary. There's nothing mandatory about the clinical trial. And if a patient wants to withdraw from a clinical trial, they can at any time. It doesn't matter when. As I just said, it is voluntary at any point. I emphasize that at every visit. If someone, just to make sure that a patient still wants to remain in the clinical trial. And one of the biggest benefits of clinical trial participation is being able to take a more active role in your own healthcare, including whether you want to participate or not. Some people feel that if they join a clinical trial and decide to opt out, then they will receive poor quality of care. This is not true. I look at clinical trials as a way of offering something that's slightly different than standard of care. And so if someone is interested in that, that's great. If they are not, I still provide the same amount of care that I would for that patient. So we just went over those 4 myths. I think the poll might be working. So which of these 4 myths have you heard before?
Ethan, it looks about 60% of people have participated. Are you able to see the results on your screen?
Yeah, I can see the results. So this is interesting. Thank you for answering the question. So I think we will address this maybe at the end of in the questions and answers. But it's good. So clinical trials, the 60% clinical trials are dangerous because they use experimental drugs. All right. Let's see. And which of these 4 common myths have you believed before? So this is a similar question, but it is different. So first one was heard, and this one is which ones have you believed?
So it looks like we're near 60%. Ethan, I'm happy to end the poll. Would you like to share the results, or do you want to wait for that later?
Yeah. So it does seem like myth number 3 was sort of the winner of, which ones have you heard about and which one do you believe? So that was clinical trials are dangerous because they use experimental drugs. And then in second place was clinical trials are only used when all other options are exhausted. And so clinical trials are dangerous because they use experimental drugs. So they use drugs that are not FDA approved, not always. Actually, some clinical trials that we do actually use FDA approved drugs and they're trying to repurpose. But a number of, I'd say the majority of studies are using new investigational products, IP, or potential drugs, in order to treat a disease. And the reason that we use those phases, so drugs don't graduate from one phase to another until there is a proven safety at each phase. So what you're not seeing is that, we talked about preclinical studies and animal studies. There's an exhaustive amount of dosing that's done prior to even giving medications to people. And then once that moves forward, we start at usually very, very low doses and give those doses just once. And we look for signs, and then they can't move on to this phase 2 until we have a good understanding of the safety of the medication. Drugs may not move on so phase 2 is usually when we start looking at in general the disease itself. And so a drug won't move on to phase 2 unless it's shown to have a good amount of safety. There are some diseases that someone may say, well, what about cytotoxic chemotherapy that my cousin or my parents had for some sort of cancer. Cancer is looked at slightly different. It's a little bit out of the scope of this particular study talking about autoimmune hepatitis, but there is a slightly different balance when we talk about cancer studies. I'm a hepatologist and I don't deal with cancer studies, so it's really important that the drugs are extremely safe before something moves on to phase 2. Clinical trials are used when all other options are exhausted. This also is, as I alluded to in the beliefs, is also not true. And it can be used, clinical trials can be used for at various time points in a disease course. I think often we use them for diseases in the refractory state. It's really where the unmet need is. So sometimes the unmet need is earlier and sometimes it's later. All right, thanks everyone for who voted. All right, so why is clinical trial participation important? So cures and treatments begin with clinical trials. In order to have new therapies, we need to have clinical trials to show that they're effective. So they're essential for developing treatments and learning more about a disease. And they help determine if new treatments are safe, effective, and can improve the standards for treatment. They bring us a step closer to treatments and cures, and they can impact the lives of many, many. They also give participants access to these medications earlier. And again, it's always voluntary. How likely are you to participate in a clinical trial for autoimmune hepatitis? For those of you who have autoimmune hepatitis. It looks like a little over 70% of people were either very likely or somewhat likely to participate in a study, a clinical trial for autoimmune hepatitis. Thanks for answering. So there are many unmet needs in autoimmune hepatitis. So there have been limited advances in AIH treatment. So the standard treatment for AIH, it's really advanced very slowly over the past 50 years, from when Sheila Sherlock started treating patients with steroids in London in the 60s. Dr. Lemmer and I still use prednisone on a regular basis, unfortunately. And fortunately, we have a few other medications we can use instead of prednisone, but Dr. Lemmer and I lament about the fact that many of our patients are still requiring some sort of steroid. And that's my next bullet point, steroid dependency. Up to 40% of patients remain on steroids for disease control regardless of duration, and that includes any sort of corticosteroid, whether it's prednisone, prednisolone, dexamethasone, budesonide. And there's limitations on the current standard of care. So there's a number of patients have inadequate response. There can be toxicities related to chronic immunosuppression. And a lot of the treatments we use are very broad and they are not targeted. So there's a clear need for steroid-free treatment in autoimmune hepatitis. So the next part of the talk, we'll be talking about the Portola clinical trial. It is a randomized, double-blind, placebo-controlled phase 2A study with an open-label extension to evaluate the safety and efficacy of Zeta in patients with autoimmune hepatitis. So key facts about autoimmune hepatitis. So it's a rare chronic liver disease in which the immune system mistakenly attacks the liver, causing inflammation and tissue damage, and this can impact someone's physical health and quality of life. So what are the signs and symptoms that someone with autoimmune hepatitis may have? And they can vary. Some of the things that I'll see is an enlarged liver or large spleen, abdominal discomfort, pain, fatigue is probably the biggest symptom that I see for new diagnoses of autoimmune hepatitis and uncontrolled autoimmune hepatitis. We can see skin rashes and itchy skin. This is pruritus is the word we use in the liver realm. You can get nausea, jaundice, decreased appetite, weight loss, joint pains. So some facts about autoimmune hepatitis: it does affect women more often than men. And if you have a pre-existing autoimmune condition, you're at an increased risk of having autoimmune hepatitis. In general, if you have an autoimmune disease, you're at increased risk of having another autoimmune disease, or if you have family members with an autoimmune disease, you're at increased risk of having an autoimmune disease compared to the general population. So the immunoproteasome, so this is a new potential target for autoimmune hepatitis. But what is the cause of autoimmune hepatitis? Well, on the left we have healthy livers, a cartoon of a healthy liver, and on the right we have what it may look like with a little bit of fibrosis in autoimmune hepatitis. And this is a cartoon of the immune cells, the macrophages, the T cells, and the B cells they normally will respond to sort of infections, but these can be overactive in autoimmune hepatitis. And what can happen is the immune system mistakes healthy liver cells for sort of other and will drive some inflammation in the liver. So what is the immunoproteasome? It's a long word. We have a good depiction of that on the right. It is a special structure in immune cells that are important for regulating the normal function of the immune system. And in autoimmune diseases like AIH, the immune system mistakenly attacks healthy tissues and can cause damage to organs like the liver. And research has shown that by blocking the immunoproteasome, you can sort of change this activity of the overactive immune system, and there may be a beneficial effect on autoimmune hepatitis. All right, so how is it different from current AIH treatments? It's a first-in-class selective inhibitor of the immunoproteasome. So it's safe and tolerable, and this has been shown in both preclinical phase studies, phase 1 and phase 2 studies in diseases other than autoimmune hepatitis. It's a once-weekly injection under the skin. It's not a steroid, and it doesn't seem to be immunosuppressive so far. And it's not predicted to result in drug-drug interactions. So the immunoproteasome is a potential new target for autoimmune hepatitis. And Zeta is different from current treatments because it has the potential to rebalance the overactive immune system that we see with AIH without directly suppressing the immune system, so those T and B cells. So the Portola clinical trial is now enrolling adults for the treatment of autoimmune hepatitis. So what we're looking to see is if this is safe and effective for treating autoimmune hepatitis. And who may qualify for it? If you were an adult with a diagnosis of AIH with active disease, despite your current medication regimen for more than 3 months, or a disease flare, and you found that your current treatments like steroids and immunosuppressants don't work well and or maybe causing side effects, and that's why you had to discontinue them. You must be willing to use and taper glucocorticoid therapy, able to return to all protocol-specific study visits, and complete all study-required procedures. So easing participation burden is a priority in Portola. So what will you get if you're in the study? There are study assessments and procedure provided to the participants at no cost. Participants receive a stipend for each study visit that's completed, usually when I talk to patients about studies, about the stipend, I say it's enough really to cover, your gas, parking, maybe a little bit more in your lunch. Usually, that's usually about what we provide. And remote home trial services are available, and so the study design is it's really an interesting one to be able to make sure that the drug can be able to be given to patients every week, but that in order to ease the burden of visits, some sites are able to use every other week home visit, which is really great. And travel concierge services may also be available. So if if you're interested in the study and getting to the site is difficult, there may be ways of doing that. And I often tell patients, if you're interested in the study, we will help figure out a way for you. We will help work with you to get you to the site when you need to be there. In general, when I work with patients who are interested who are in a study, I also tell them that, as long as you're coming during business hours, we can see you on any day of the week. What I often say is, if you make an appointment to see your doctor, you have to make an appointment at, say 10 a.m. on a Monday. Whereas if you're in a study, you tell the doctor what time you can be seen. So it sort of flips around. What to expect, step-by-step process. So there's a screening period. This is up to 5 weeks, and this is where we make sure that someone is eligible for the study. So you don't want to be in the study if you're too healthy to be in the study. So, or if you're too sick. So we make sure that really you're sort of the Goldilocks approach, just right to be in the study, that this may benefit you. And so that's where the screening period comes in. And then the treatment period. So there's two phases, two parts to this. There's a 24-week treatment period where patients either received Zeta or placebo under the skin for 24 weeks. And then there's an open label extension where everyone, this is to borrow from Oprah, this is where everybody gets the drug. This is the open label extension part. And I think this is great because enrolling in a study, we're trying to sort of get that balance. I think when someone is in a study, they'd like to get access to this, the potential new medication to help a disease and during the treatment period, it's actually the ratio is not 1-to-1. It's 2 patients get the Zeta to 1 patient getting placebo, so that's better than 50-50. And then the open label extension is anyone who wants to stay in the study is able to stay in and receive the IP. Follow-up period is 4 weeks afterwards. So in summary, clinical trials, they don't always have to be the last resort when all other options are exhausted and can include participants with various stages in their disease journey. Often use placebo, but rarely ever using placebo alone. And we do prioritize patient safety and only use investigational drugs after they've undergone extensive preclinical testing. And you can withdraw at any time if you're in a study. It's always voluntary. So if you're interested in learning more, here are the QR codes for both the clinicaltrials.gov site and the Kezar site. So with that, I'm happy to take any questions Dr. Lammert and I can help answer regarding autoimmune hepatitis or the study or clinical trials.
Hey, Dr. Weinberg, thanks so much for that excellent talk on 4 really important points that I've heard in clinical trials that we've run here at Indiana University, and even relevant for the zetomipzomib study as well with Portola. Maybe just to kind of get us started, there is at least one in the chat box, and we can let others chime in. You had mentioned one word, maybe you could clarify. You mentioned that this is more related to the Portola study about first in class. What does first in class mean for patients, drugs? And we hear that used a lot. I just want to make sure patients understand what that means too in this study per se.
Okay. So there is not an FDA-approved medication right now that targets the inflammasome. The immunoproteasome. And so that's where this is if it were approved, this would be the first drug to be approved with this target. And someone would say, well, is that a problem? Should I be concerned about that? No, because as I alluded to it in the other parts of the talk, every phase is studied extensively to make sure that it's safe to move on to the next one. So what it does mean is, there may be a little bit even more attention to make sure that that it's safe. But so far, all signs are showing that in the patients that have been tested so far with this, that it seems to be extremely well tolerated.
Great, thank you. And again, just to note to our participants, if you have a question, if you would mind using your raised hand function on the Zoom call, we could also just have you open up your mic as well. But there was a question in the chat box from Galiko. She had another question about zetomipzomib clinical trial, and she had read the information we had shared, but she was wondering if this medicine is considered in patients with liver cirrhosis. Dr. Weinberg, could you address that?
Yes. So if a patient has cirrhosis, they may be a candidate for this drug. It really depends on how much inflammation is going on in the liver at the time, and also that they do not have decompensated cirrhosis. So decompensated cirrhosis, as I explained to my patients, is we can look at cirrhosis in sort of two different ways: compensated and decompensated. And compensated is you walk around the grocery store, no one would have no idea that you had liver disease. And decompensated is you actually have some symptoms of end-stage liver disease. And so the Portola study is actually open to patients with compensated cirrhosis. But if you have decompensated liver disease, there are clinical trials that are usually that is maybe the inclusion, because at that point, how a drug is broken down by the liver may not be as reliable. And so we often shy away from using from clinical trials for decompensated cirrhosis until it has been shown to be safe in all other aspects of liver disease. So that's where our breaks are.
Yeah, I think that's helpful, Dr. Weimer. I appreciate that. And another question, there's a follow-up one to that one, but just on another little kind of deviation, I think this is an interesting one in terms of how you approach patients with clinical trials. And Andrea says, how do you help patients to choose which clinical trial to either attend? And maybe I'll rephrase it a little bit. How do you help them to consider a clinical trial, maybe specifically in a rare disease?
So I talk to patients about what their options are at the time. So for autoimmune hepatitis, if someone is having a poor response to their current treatments, I'll say, okay, these are the other treatments that you could have. And a clinical trial is one of the other treatments. So it's not often, it's very rare that I say this is the only option left for you is a clinical trial. That's not usually the case. There are usually always a few different options. Some of them are better than others, and the clinical trial is one of the options. And so it's up to a patient to determine what they feel comfortable with, and sort of that has to do with the side effects of what the other medications may be, as opposed to the side effects of the clinical study. I've also had patients that are interested in clinical trials, but they're not able to commit time to the current clinical trial, but they sometimes will say, I can't do this one, but if you have another one that has less visits, maybe that's fine. So the clinical trial there is a certain degree of commitment that even if you may want to try this new medication, may not be able to. And so it really is just it's another treatment that I offer, A, B, or C, and I like to talk about the pros and cons of each of them, and to help patients make a decision on what may be best for them.
Yeah, no, that's great insight. There's another question about age limit for this study. Dr. Weinberg, do you know off the top of your head if there is a upper age limit for enrollment?
Give me 1 second. I think I can pull that up. I don't know off the top of my head, but I can find out very quickly.
Yeah.
Oh no, I can't. Sorry.
And Ethan, while you're looking that, maybe I can address another one. Galiko had asked another question. She's considering this trial. Do we know yet in terms of duration? So again, once a week for 24 weeks and then another 24 weeks. I think she's speaking more to, yes, the trial is for 6 months, but then moves into an open label. So
Yeah.
again, the duration of the label is, to my understanding, is at least another 6. But again, beyond that, I don't know if I can speak more to that. And I don't want to put the Kezar Life Sciences representatives on the spot here, but at least I think that's what we can say for at least the near future.
Yeah. Yeah. So it depends. I think when I've talked to patients about this, I say that we have this the first arm of the study is 24 weeks, and if you find that, again, it's voluntary. If someone said that the demands of treatment were too much, or they had something else happen, they could leave. But that's the open label is also, it's sort of it's the optional of the voluntary is the way I put it. If someone is signing if you're signing a consent form to be in the study, you're really saying you would like to be in the first part of the study, and you can be in the second part, but you can also end after the first part if you're not interested in remaining in the study. So, they're different duration. Now, I would say if you get through the first 24 weeks, I would say is the harder part, and then you get with the open label, it's what you're getting as well. And so if you find that you're getting benefit and you're not, and the burden of the study is not too much, then I think it's important that the investigator talk with their patient about whether the sort of open label part is a good fit for them. And then there is no upper age limit. It's 18 or older.
Great. That's great. Thanks, Dr. Weinberg. Just a few other comments, and again, we can hold for other participants' questions as well. But from the Autoimmune Hepatitis Association's perspective, we've done a number of different things over the past year or two, one on our own, but one with the FDA, to listen to patients, to understand a little bit better about unmet needs in this disease space. And Dr. Weinberg has talked a lot about these throughout the course of his talk. But a few things that necessarily didn't come up per se, we really need innovation in this space for treatment. Again, Dr. Weinberg talked about the dependency on corticosteroids in a very sizable chunk of patients with autoimmune hepatitis. And I think this has gone unnoticed for many years, and actually our approach to using steroids so much is actually quite antiquated in relative to other autoimmune diseases. So we know we need better, but again, I think historically we've always just considered these therapies were good enough. So we love that, again, we have a new clinical trial to consider. And again, our hope is that maybe we'll have other future trials in this space until we kind of figure out what is best, or maybe we could move to more of a precision model. But patients have talked about the importance of moving away maybe from a model of daily oral therapy for treatment, and maybe moving to something that's injectable or infusional. And I think, this is one thing that this study does allow, at least with weekly injections. So certainly, again, trying to address that. We also, from the nonprofit's perspective, we want to encourage the recruitment of people of color into these clinical trials as well. And that's one thing that's been really clear. Data for autoimmune hepatitis, particularly in clinical trials or prior exposure data for azathioprine CellCept, have often been misreported in Caucasians, and typically of European descent. We know this disease can be very different. So again, we want to try to pursue this. And again, this trial has been opened at a number of different academic centers across the United States. And ultimately, we think that will bring in more diversity, which is critically important. I'll ask the audience again if there's any other questions for either Dr. Weinberg, who gave this excellent talk, or even myself or other members of our nonprofit. And if not, we can call it a day. Dr. Weinberg, any other closing comments about the future of autoimmune hepatitis, clinical trials, or there beyond?
No, I think if you're interested, I think it's great if you speak with your prescriber, whoever treats your autoimmune hepatitis, on whether a study is right for you.
Yeah, no, I think that's great. One last plug from our perspective. You can get more of Dr. Weinberg and myself. We have our patient education support meeting coming up in Indianapolis here on October 13th and 14th. More details can be found on our social media channels, Facebook, but also our website at www.aihep.org. Just a gentle nod to Kezar Life Sciences as well for being a key sponsor for that patient conference. But we've taken a lot of great care working with a conference planning committee that's composed of healthcare providers, but also patients, to make sure we bring the most important talks in an educational format, but it's also patient level, but also community building. So we'll have a lot of opportunities there, and also participate in research, Indiana University. So this will be our 7th conference. And again, it's nothing short of magical to get a lot of AIH patients and their families in one room and in an environment where people kind of get it. So again, personal invitation, we'd love to see you more. So, but thanks again, Dr. Weinberg. Thank you, Kezar Life Sciences, and thank you to the Autoimmune Hepatitis Association for making all this possible today. We really appreciate it.